Hi.
All right, so up next, we are supposed to have a research meeting, which is kind of fallen apart a little bit. And so what I'm going to do is actually give you guys just kind of a brief overview on some of the stuff we do, or some of the stuff that I think about on a daily basis, which is metastatic disease for the brain. And I apologize, I'm actually in the middle of a clinic here. And so I may get some interruptions, but we'll try to make it short. That way everyone gets out on this beautiful 90-degree day, and we can, end a little early today. I'm looking at the comments. I see you guys thanking them. Was that meaningful? Was that a great lecture, or what? Yeah, they're absolutely powerhouses in the field, and it's great to hear from them and hear their story. Give me 1 sec. I'm going to pull up my PowerPoint here. All right, let me see if I can share. All right, can everyone see my screen?
Yeah, we see.
All right, perfect. So yeah, so I think I mentioned this to you guys the other day, but my primary specialty, I'm gonna leave the chat open too so we can talk. My primary specialty is neurosurgical oncology. That's what my passion lies in. That's what I deal with for the most part. And there's different aspects. When you subspecialize in neurosurgery, you can even further subspecialize. And one of the things I've become really interested in is brain metastases and spine metastases, because they really, traditionally brain surgeons would do brain tumors, spine surgeons would do spine tumors, but in reality it's understanding oncology that's kind of at the root of these things. And I think that for any neurosurgeon in training nowadays, you're going to get understanding of how to treat both of these things. And so if that's your interest, if oncology is your interest, you can do both and contribute, I think, meaningfully to the care of these patients. And so what are CNS metastases, right? And so what do I mean by that? So a metastatic brain tumor or spine tumor is a secondary tumor, meaning that you've been diagnosed with cancer somewhere else in your body. Sometimes it presents just in your brain or your spine, but typically this cancer came from somewhere else. And the cells actually break free of the tumor and they spread through your body, through the bloodstream, and they kind of seed in different places. And where they go is, commonly in the brain or in the bones of your spine. And when we talk about brain tumors, we often talk about glioblastoma. Everyone kind of knows about that. But brain metastases are actually 5 to 10 times more common than primary brain tumors. And you'll see also spine tumors as well. And so who gets these, right? And the most common types that we get are lung, breast, melanoma, all right? And then some other types also get there. I actually have a patient with thyroid right now, which is extremely rare. And if you look at the numbers, about a third of patients with cancer are going to develop a brain metastasis at some point. And that's due to a number of different reasons, right? Number one, we watch these patients closely. Number two is we're getting better at treating them, and I'll show you a slide about that later. And then the whole population is aging, right? And so your risk goes up after about the age of 45 if you have cancer, and the highest risk is over 65. And the type of cancer matters to some degree, right? So lung cancers, like I said, are most common, and that's because something about the genetics or the molecular phenotype of these cancers that promote their ability to kind of metastasize to different regions, and especially to get into the brain. And then certain mutations, things like that. Now, spine metastases, again, I told you that this is more common than you think. If you look at cancer patients on their post-mortem exams, 70%, greater than 70%, have evidence of spinal disease, which is a huge number, right? And we're able to see this more because we're using more PET studies, which is a kind of a nuclear medicine study. And again, patients are living longer, right? And what happens is that some of our new treatments that treat cancer are better for actual disease elsewhere in the body, but not in the bone necessarily. So it's getting left behind. And so, we said about a third of patients are going to develop a brain metastasis. Over 70%, right, 2/3 or so are going to develop spine metastases. But luckily, only about 10% of patients with spine disease are going to develop a symptom due to this. And that's, an important number to understand as well. And so what about spine? Who goes to the spine? So prostate cancer likes to go to the spine. And it's probably just due to sharing blood vessels with something called the Batson plexus in the spine. It's a venous system. Breast cancer likes to go to the spine. Lung cancer likes to go to the spine. And then there's this other big category of, this 26% number in red there, which, is variable. And then most commonly it goes to the thoracic spine, and that has to do with blood supply. There are very large arteries that go to the thoracic spine, and, cancer tends to travel in the bloodstream, and that's how it gets places. Now, when does it happen, right? So it can happen years after you've been treated and diagnosed with other cancers, right? I've had patients who have had a lung cancer removed with negative margins, negative lymph nodes, then 4 or 5 years later, something presents to their brain and their spine. In melanoma, very classic for this. You can have a melanoma removed, and then one day it just comes back. It can be 10 years later. It's pretty impressive, actually. Some tumors go very quickly, and they're actually identified first. So patients come to us because they had a seizure or a new headache, and we diagnose them with a brain metastasis. And that's the first kind of inkling that they have cancer. They haven't been losing weight. They don't have any other symptoms. And then in some places, it's actually pretty remarkable. The body itself, using your immune system, is able to destroy your primary cancer. So you don't have any evidence in your body, but you find it in the brain or in the spinal column. And the brain is more likely in that situation, and that's because of something called the blood-brain barrier, which limits, the immune system from getting into the brain. And so, how do you know that you have this? All right. And so, with brain tumors, it's all about location, right? Where does it show up in the brain? So, some people develop headaches. They can develop seizures, weakness in the arms or legs, balance issues, memory problems, speech problems, behavior problems. A whole list of things, and it all depends on where it is in the brain, because every part of your brain does something different, right? It's all important. In the spine, people end up with back pain from fractures. The tumor itself kind of degenerates the bone faster, and you can have a fracture. What we worry about the most, though, is when the tumor grows into the spinal canal and starts compressing your spinal cord. And that's where people present to us unable to walk anymore, right? Severe back pain, progressive inability to ambulate, and then worse kind of situation is called a equina situation, or a cord compression, where they're completely flaccid paralysis, right? They no longer are able to walk or control their bowel and bladder. Those are dangerous situations. And so how do we diagnose a metastasis, right? So imaging is key. So patients who have cancer undergo surveillance imaging, something called PET scans, which looks at uptake of the cancer by certain metabolites that they give it. And once they see something, then you get another scan, typically an MRI or a CAT scan. We diagnose it typically with a biopsy, unless you have a known cancer, in which case we already know what we're dealing with. Although we're biopsying more and more, and that's because the treatment depends on the molecular and genetic features of this tumor, right? And so we want to know exactly what we're treating. It turns out that when cancers go to the brain, if you were to compare the genetics of a brain metastasis versus your systemic metastasis, about 60% of these have differences. And so the tumor changed in order to get to the brain. And you're treating sometimes a different tumor. And the real question is, are any of those changes targetable, right? Can we look at that tumor and say, no, this is something we can target with a special chemotherapy or a special immunotherapy, a special biologic agent, or not, or sometimes it's the same. And then PET studies we kind of talked about. And so what needs to be known about this is that they're all treatable, all right? Cancer itself is not curable, except in very rare circumstances, but we're very good at treating these, okay? Brain tumors can be treated with surgery and radiation, followed by systemic treatment. We're very good at radiation for these things. And spine tumors, it turns out, the same way, typically more reliant on the systemic treatment, although radiosurgery, which I'll show you guys soon, has had really significant benefits. So what matters, though, is the type of cancer. What are you actually treating? How well you've responded to previous treatments. When we talk about treating cancer, we talk about lines of therapy. And so your first line is your kind of standard care that everyone's going to get. And then you fail at some point. The tumor mutates, the cancer spreads more, and you go to your second line and third line. And depending on your responses to previous treatments, as well as this idea that you have more treatments available to you, dictates whether or not we're going to intervene or not. Because what we don't want to do is hurt people, right? That's the standard, kind of sentiment in medicine. And so we're not going to give you chemos that aren't going to work because you're going to get sick from them. and your cancer is going to progress. The location of things is paramount when we're talking about anything CNS related, right, in the brain or the spinal cord. And then just the general health of you. If you've lost 100 pounds, you're 80 pounds soaking wet, really degenerated and dying, then again, we're not going to treat you because it's going to hurt you more than it's going to help you. And so where do we start? So a lot of times now, surgery is not the immediate answer. We actually go to radiation. Because we have such good surveillance, we identify these tumors often when they're very small, and sometimes haven't even caused a symptom yet. And so this is a gamma knife unit, which you see here, which kind of sends radiation from all different angles to a focal point where it delivers a very high dose of radiation. It's very precise. We're talking about sub-millimeter accuracy. And it's painless. You just lay on this table, and you sometimes have to put your head in a frame, or sometimes you actually put a mask on that keeps you immobilized while the radiation passes through you. And that gamma knife is just one type. Whole brain is another type. External beam is another type. And these are all kind of tools in our armamentarium that we can treat cancer in the brain. And we do this for spine as well. And so stereotactic radiosurgery for the spine is probably the single greatest advance in the management of spinal metastases. And we give a very high dose into a very focal area, which allows us to treat with less side effects. And it allows us to shorten the treatment. And this has really kind of changed the game, because for local control rates, that's what an LCR is. We're seeing 2-year LCR of 98% in tumors of the spine treated with SRS. Now, again, this is local treatment, so it's not treating your systemic cancer. But what I tell patients nowadays is that we've gotten really good at treating metastases to the brain and spine. And so honestly, what ends up killing patients is their systemic disease, their burden of disease, and their inability to kind of have options left. So we have to talk about surgery, because this is what I do. And so who is the best brain tumor candidate, right, for a metastasis anyway? So we talk about large symptomatic lesions in patients who have good functional status. And what that means is someone who still works or is able to take care of themselves, to get themselves to appointments, someone who's going to be able to participate in their care when there's significant mass effect and someone's symptomatic. So the brain tumor itself is there, plus the swelling around it, and someone can't move their right arm anymore, or someone can't walk anymore, or they can't speak. That's an area where we're going to say we're going to go in because we're going to reduce that swelling faster and take the pressure off the brain by doing this. If someone needs a diagnosis, it's going to permit that, right? We can take that tumor tissue out and get an understanding of, did it come from the lung or is it a melanoma? And the whole goal here is always safe maximal resection, meaning we can get the whole thing out without affecting you negatively or your neurologic function. What we don't want to do is take someone who's functional and make them non-functional, right? And then what we want to see is a clear correlation. So if you come in with left arm weakness, but you have a left-sided tumor, it doesn't make any sense. That's not an argument to go take out that 1 centimeter left-sided tumor, a small thing. You want to see a very clear correlation of the tumor causing a problem. You also want to make sure, we've talked about this a few times now, that the primary tumor itself is treatable, right? If we don't have any treatment options for you, why are we going to do a brain surgery potential cause a problem? All we're going to do is, again, hurt you. And when we look at the best evidence for this, we want to see 1 or 2 or maybe 3 tumors that are close together, can be removed kind of in the same setting. You don't want to be doing surgeries on all sides of the head. Although I will tell you that I've done it before. In certain circumstances, it is necessary. And so this is kind of these indications for brain tumors specifically. We want to see a limited number, significant effect, whether it's due to the mass or symptoms. We need a diagnosis. And then when do we go SRS, right? So stereotactic radiosurgery, that gamma knife, which I think someone just asked a question similar about this. So we'll do stereotactic radiosurgery for a limited number of tumors. It's actually not the number of tumor, it's the amount of tumor that probably matters more. So nowadays we'll treat up to 10, we'll treat up to 20 if they're small. And then this is an adjuvant. So after a resection, you always want to give gamma knife, because there's cells that are left behind. Even if you get the whole thing out on an MRI, there's always those cells. I don't know if anyone was here the other day when I talked about the spaghetti sauce analogy, right? You can take out the meatball, but getting the spaghetti sauce off with a knife and a suction is probably not that easy. Whole brain radiation is for these people who have too many lesions, right? We've seen patients who come in with too many to count, greater than 20. Then you radiate the whole brain, because you're going to affect some treatment response on these things. But whole brain radiation therapy is tough, because whole brain radiation affects the whole brain. And so patients have cognitive difficulties about 2 years afterwards. And we've tried different techniques for that to spare an area called the hippocampus, which seems to help. And realistically, you need to demonstrate some sort of response. This is, it's a salvage therapy at that point. And then your systemic treatment for brain metastases is very tough because most chemotherapies are large molecules that have a lot of difficulty getting through that blood-brain barrier. And so in general, systemic therapy is not a first line for brain metastases. That said, nowadays, we have targets, right? I told you, we characterize these tumors, we figure out who they really are and can we target something. And so this whole game is going to change in the future. And that's kind of what excites me the most about it. That's why I want to be involved, is I want to understand moving forward, how do we take what's, this list here of resection, radiation, systemic, it's a general list. It's like saying, well, we're going to, change the tires on all the cars. I don't want to do that. What I want to do is I want to change the special tire on the Ferrari, right? You want to be very, very specific in what you're going to do. And that's, I think how we're going to affect meaningful or, cause meaningful change. So this is kind of an algorithm you can use for brain tumors. Is there one brain tumor? Does the patient have a good performance status? Is it small or big? If it's small, does it come right to the surface? Do we need a diagnosis? Or can we just go straight to radiosurgery with it, right? Or is it big? In which case, what's the patient's, prognosis, and is it worth taking this out? And so this is something that I kind of think about internally, with every single one of these cases. And it turns out that like I said, we're pretty good at this, right? We are able to, for a single metastatic lesion, surgery improves overall survival. It decreases the rate of recurrence. It improves quality of life. This has been shown in studies. The intervention actually may, like I told you, you don't just need one tumor, up to like 4, where you can get the whole thing out with, minimal kind of negative effects to the patient's quality of life, you could argue. And these are just prognosticators down at the bottom here about, how fast are these people progressing, how many lesions there are. An RPA classification is a scoring system that you don't need to worry about. I just want you guys to get an understanding of how we think about every single patient who comes in like this. And we see what the survival is like. Now, these numbers are scary, right? We're talking, 12 months is a year, right? And all these numbers are under a year. But what I think is most important about this figure is these error lines, right? Look at the error line for breast. Some people are a lot less, but some people are a lot more, right? And this is an old slide, but it kind of speaks to the difference within individuals' tumors, right? So the variability with the genetics of these tumors and the ability to target, this is why I say that what we need to do is treat every single patient as that patient, not as every single patient with a breast tumor, all right? And that just comes from further study and further involvement in these things. So when we talk about spine surgery, what's our goal, right? We have to talk about neurologic function. If someone comes in paralyzed, we need them to get better. We have to talk about, controlling the tumor. We have to talk about their mechanics, right? The spine is, as you just learned with Dr. Rizzulli today, multiple integrated pieces, right? And if you disrupt the stability of that spine, patients are going to have all the symptoms of spine problems. They're going to have back pain. They're going to have horrible quality of life. They're going to have instability of the spine and movement, compression, and neurologic elements. So we need to address stability. We don't have to do that with the brain. The head stays on the head for the most part. Pain relief, quality of life. And so people out of Memorial Sloan Kettering devised this framework. And, it's been validated to a degree, but it's called the NOMS framework. And what we care about is the neurologic function, the oncologic disease itself, the mechanical stability of the spine, as well as the systemic disease of the patient. And what we see here is when we talk about neurologic, we actually, we care about your symptoms, but what we really care about is the degree of compression of your spinal cord. Because what we know about this, and we'll talk about it in a minute, is if you can't use your spinal cord, you will not live as long. All right. If you cannot walk, you will not live as long. And so more so than just, doing a physical exam and saying, oh, well, his arm is 4 out of 5. No, what we care about is how close is the tumor to the cord. And the reason this is important is because we can radiate certain things in this area with targeted stereotactic radiosurgery, but we cannot radiate the spinal cord to a high degree, or we will cause the problems we're trying to prevent. All right. So this is the oncologic portion of this when I say we need to know about the type of disease. And again, we care about this in the setting of how it relates to radiation. So this has to do with radiation response based on certain types of cancer. We see breast is very responsive. Lymphomas, myelomas, we don't even need to do surgery. We can just radiate them. The tumors will essentially disappear. Prostate cancer, variable, and then we start getting into these other types. Now, if you look at these other types, based on what I told you are the most common cancers, we see that lung cancer, very unresponsive, melanoma, very unresponsive, all right? And so now we need to, we needed to change how we did our radiation. This was external beam radiation, which is a broad field. This is what led us to start doing stereotactic. So when we look at normal conventional radiation, we see with the sensitive tumors a response duration that's about 11 months, all right? We see 2-year local control of 86, all right? 86%, sorry. With the unresponsives, look at this, 2-year local control rate of 30%. That means that radiation is not doing much, right? It means the tumor is going to come back. The response duration with these unresponsive tumors, 3 months. That's sad, right? That's not useful. And so we start again thinking about kind of what are our things, radiation, systemic surgery. And it turns out that with radiation, the dose really matters, okay? When we do stereotactic radiosurgery, where we can deliver this higher dose, we're getting, look at this, 3% local failure with high dose stereotactic radiosurgery. It does not matter all of a sudden what type of tumor it is. Histology is not important. What matters is the dose of radiation to these tumors in the spine. And that's a really important understanding. And so this I kind of mentioned already, 14 gray, we measure radiation dosing in gray. It's a little bit above your guys' heads, I think, but it's 14 gray is the highest dose the spinal cord can take before we can cause an injury, which is why, again, it's really important to, make sure we have space. And that's a concept that I'm going to go into next, which is space, right? If the tumor is completely compressed in the spinal cord, you don't have space, the spinal cord is going to get radiated. And so when do we do surgery? And that's actually the perfect situation, is when we need to make space for the spinal cord. And so the original study that looked at this by this guy Patchell showed that decompressing the spinal cord was extremely beneficial to the patient. I'm going to skip to the next slide, actually, because I think it's a little bit more important. Maybe not. It's this one. What we look at here is, let's see. So these factors, they're really small, I apologize, but the ability to maintain your continence is super important. Being able to maintain your ability to walk, being able to have decreased, pain medication requirements. These things all affect quality of life. And most importantly, they affect actual oncologic outcomes, meaning how long someone lives. All right. This ends up being our framework for the NOMS criteria. So do you have low grade or high grade spinal cord compression with symptoms or not? Are you radiosensitive or radioresistant? Spine mechanics are very important, like I told you about, and there's a way to identify who's unstable and who's stable. And then can you actually tolerate surgery, and do you have treatment options left, right? These are really important things. And then we do some degree of treatment, stabilization with radiation, just radiation, decompression stabilization with radiation. So there's a whole array of kind of options available. And so how do we do? Again, we talked about this kind of a few slides ago, but with this high dose radiation localized to those areas, we see that patients do better. And this is, again, totally does not depend on what type of tumor you're treating. If you've had other radiation to this area, or if there's epidural extension, as long as you can decompress the spinal cord surgically. And then chemotherapies, I kind of addressed already. Targeted therapy is the future. It's here now, but it's really the future. So what are some of the things we offer here? So for brain, we talked about this the other day, cortical subcortical stimulation, again, safe maximal resection. We're not going to cause a problem. We have our exoscope, which improves visualization. That's the whole team C, very high def. We talked about gamma tau the other day. SRS, we have the ability to do that. The Metastatic Tumor Center, which is what I'm launching, this year with my collaborators here, is a big deal, because this is not just my decision. It's really the decision of myself, the oncologist, the radiation oncologist, the palliative care team, the nutritionist, the primary care doctor, as well as the patient and their family. So you all of a sudden have this multidisciplinary approach to it, and it proves to provide very interesting ideas that I think are important to people. For the spine, we didn't talk about this much, but let's say you have a tumor in the spine that's not compressing your spinal cord. We can do kyphoplasty, put cement into that bone to treat the pain associated with that. We can do minimally invasive surgeries to stabilize kind of instability in these situations where maybe just one component of the bone is involved that creates movement in the spine. We'd have the stereotactic radiosurgery. Osteocool is a radiofrequency ablation for tumors in the bone that also helps with pain. And then we do our open surgery. And I don't need to go into too much of this, but we use ultrasound in the operating room to make sure we're fully decompressed. We use carbon fiber screws so they don't have artifacts on our MRIs, so that we don't need other special, more invasive imaging to see the tumor to plan the radiation. And so, this is all the areas where we're really kind of pushing the envelope and moving the needle. And what I can tell you is, this is not just our idea, right? This is all of neurosurgery and oncology, radiation oncology has looked at this, and we look at how we're doing with cancer over the, it's not really the past 5 years. I think this is from 2013, but it compares from 1970 to 77 to 2007 to 2013. And we're talking about overall survival rates, right? And all those arrows are pointing forward, right? So we're doing very, very well in this. And I would love to see what the numbers even look like in the past 5 years as the science behind it advances. So I'll take a couple minutes to take questions from you guys. But I do apologize. I'm going to sign off a little bit early. We're going to end at 11:30 today. Let me get out of here. All right, I stopped sharing. Let's see. The attitude of the patient moving forward is incredibly important. And I don't know the molecular behind it. I don't know if it has to do with the stress hormones. I think it has more to do with this effect that we see a lot of times with patients getting involved in clinical trials, which is that if you watch someone, they do better, right? And so if you have someone who wants to be involved in their care and is going to be very proactive about their care, they're going to do better. Now, there's another confounder in that, which is that for them to be that involved and that active, they probably are better to begin with, right? They don't have as much disease burden. And so, there's a lot of things that kind of go with that. Give me one sec, guys, if someone asks me a question. What else? Could those vectors be used to treat brain? You're talking about GBM, you're talking about microbial vectors. They could be, but it's not 100% necessary. GBM is still kind of the toughest of these diseases to treat. We don't need to, we're not, I think the most important thing for brain metastases is what we're targeting for treatment, not necessarily drug delivery. Although, because again, we're very good with the radiosurgery. Now, intraarterial therapy, though, could be beneficial here. And I think that's something to think about, how we deliver drugs to the brain because of the blood-brain barrier. Blood-brain barrier remains a limiting factor in a lot of things. Can SRS be used with open MRIs for better outcomes? I'm not sure what that means. SRS is not delivered in an MRI. It's delivered on a totally separate bed using the MRI. So I'm not really sure. I can't find you on LinkedIn because I'm not on LinkedIn. But you can find me on Instagram and I guess TikTok too. And I guess Facebook. Do people still use Facebook? Is this field a mainstay of neurosurgery? Absolutely. Every neurosurgeon out there can deal with cancer. But I think that subspecialization is important. And subspecialization even within your specialty is important because it's very hard. It takes a certain amount of hours, right? Everyone's read that book or heard of that book to become an expert in something. So it's very hard to become an expert in one thing, which is already a big enough field if you're spread thin doing other things, right? And so I think that the subspecialization, it makes you an expert. And what do you want to be? Do you want to just be, mediocre or good at a lot of things, or do you want to be an expert in one thing? And so I'm kind of in the latter category there. As a neurosurgeon, how often do you see patients tried holistic spiritual treatments? I see it a lot. And I think if it makes you feel good, do it, but you have to be very realistic about what treatment you really need. And so if you want to do acupuncture, if you want to do, I don't know, turmeric or anti-inflammatories, do it. It's, as long as it's not going to hurt you, that's fine. If it makes you feel better, do it, but don't not get chemotherapy because it's, you need chemotherapy. How do you approach conversations? Exactly like I just told you right now. I have the same exact conversation, multiple times a day with people. I'm very, very frank with people about everything because I think that people need to hear what's going on with them. As a student under the age of 16, I've had difficulty finding data doctor shadowing experiences. Will we continue with brain tumors? It's a great question. I don't know the answer to that yet. We'll see how the reviews are this time around. But I would tell you, under the age of 16 is just hard. Just get a little older, keep doing stuff like this, demonstrate your interest in it, and find people close to you who may be able to get you an in. Remember, I think I told you guys the other day, connections are critical. You need to establish connections with people. Does whole brain radiation do better in killing residual cancer cells? Absolutely not. SRS is better. Higher doses are better. What made me want to do neurosurgery? It's a whole other lecture. Advancements in med-onc, lesser role of surgical interventions. I hope so. Right. I told you guys the other day, I mean, look, I'll be out of a job, but surgery is like rudimentary, right? We're trying to cure people with steel and string. I think I mentioned it. If you look at surgery or like medicine, like warfare, we're still in the Stone Ages, right? I mean, we're treating things with, we're changing genes with CRISPR, right? We're so far advanced that I would hope that we can eliminate this completely without the need for surgery. What else? Peripheral cranial nerves glow. Yeah, someone's talking about fluorescence. Yeah, I'm super interested in this. I'm glad you brought it up. It's very possible, very real. I don't know how to do it. But you don't necessarily need to make the peripheral nerves glow. What you need to make is the pathology glow, right? And then you go to the thing that's not glowing in the dark. But one of the other things I'm super interested in is, you know, I told you about cortical mapping, but why can't we make function glow, right? Why can't we make the functional brain fluoresce in real time so that while we're in the operating room with an awake surgery, someone wiggles their fingers and that area of the brain lights up right there, right? So I think, you know, these are the right kind of questions you want to be asking, and then find someone who can help you make it happen, and then tell me about it so I can, you know, do better surgery, or you can come work with me. It'd be great. Research opportunities, interested in a project or topic. Yes, we do, but it's a slippery slope. So if you're interested, just always reach out. We only have a limited number of stuff we can possibly do, right? And, you know, the people, it's competitive. So I would never limit any of you, but I think if you're interested, reach out. So anyway, guys, I'm going to jump off now. It's 11:30. We're ending a little early. Thank you so much for your attention again and your participation today. We will see you tomorrow. Let me see what the schedule looks like tomorrow. Quinn, do you know what it is?
Yes, I do. I have it right here.
Cerebrovascular virtual OR. Is that with Langer tomorrow to start?
Yeah.
I think Dave Langer is going to make his first Brain Turns appearance of this season, so make sure you jump on. We have actually an interesting talk by our PAs. They put together a little 2-session kind of segment on what it's like. You know, physician isn't everything, right? PAs are a huge part of the team, nurses, nurse practitioners, administrators. We've dealt with this in previous sessions, but they put together a nice piece for us. And then actually we have nursing to follow with Lisa Peters, who's, you know, head of nursing here. And she'll give you a talk about kind of the nursing aspect of things and how it's involved in medical care. And so make sure you come in. Fridays, our chairman's corner. It's 100% Langer, 100% of the time. It's going to be great. And have a great afternoon.